Myself, Usman, working as a brand manager in Wilson Pharma. I formally welcome you all on behalf of Pakistan Society of Echocardiography and Wilson Pharmaceutical or on fourth event of Masterclass Imaging Talk. For further proceeding, we will start with the recitation of Holy Quran. Dr. Shahun Saab आएंगे inshallah for recitation of Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم ياسين والقرآن الحكيم إنك لمن المرسلين على صراط مستقيم تنزيل العزيز الرحيم لتنذر قوما ما أنذر آباؤهم فهم غافلون لقد حق القول على أكثرهم فهم لا يؤمنون إنا جعلنا في أعناقهم أغلالا فهي إلى الأذقان فهم مقمحون وجعلنا من بين أيديهم سدا ومن خلفهم سدا فأغشيناهم فهم لا يبصرون وسواء عليهم أنذرتهم أم لم تنذرهم لا يؤمنون إنما تنذر من اتبع الذكر وخشي الرحمن بالغيب فبشره بمغفرة وأجر كريم إنا نحن نحيي الموتى ونكتب ما قدموا وآثارهم وكل شيء أحصيناه في إمام مبين صدق الله العظيم.
Jazakallah Shahun. For further proceeding, I would like to call upon Professor Fateh Ali Tipu Saab, who is also General Secretary of Pakistan Society of Echocardiography.
अस्सलाम वालेकुम। पाकिस्तान सोसाइटी ऑफ एकोकार्डियोग्राफी, जैसे शहबाज साहब ने अभी थोड़ी देर पहले ही बात कर रहे थे कि पहले काफ़ी लंबे अरसे तक डोमेंट स्टेज में रही है। लास्ट ईयर हमने जब इसको एक्टिवेट किया तो उसके बाद से ये फोर्थ सेशन है हमारा, जिसमें कि हमारे पहले 2 टॉक्स हो चुकी हैं और एक सेशन इंटरेस्टिंग केसेस का हो चुका है। तो आज हमारे पास 2 स्पीकर्स हैं एंड बोथ आर वेल नोन स्पीकर्स। सो जो पहले स्पीकर हैं डॉक्टर इमरान हमीद साहब, उनके बारे में थोड़ा सा मैं आपको बता दूं उनका इंट्रोडक्शन। ही इज़ अ फाउंडर मेंबर ऑफ पाकिस्तान सोसाइटी ऑफ एकोकार्डियोग्राफी एंड ही इज़ अ मेंबर ऑफ अमेरिकन सोसाइटी ऑफ एको. He developed the web page of Pakistan Society of Echocardiography, which would soon be active and would be open for all of us. And he has published a lot of articles, and besides numerous articles published in national and international journals of cardiology, he has published 6 articles exclusively on echocardiography. And today he will talk about strain imaging. So welcome to him. Please, Imran.
Thank you, Tupu, for a nice intro. And I would also like to thank Pakistan Society of Echocardiography to provide me an opportunity to talk on one of the very important topics in echocardiography nowadays, which is spectral tracking and strain imaging. Now, with the advent of Pakistan Society of Echocardiography, I think, inshallah, all the modalities of echocardiography will be covered by presentations like this and sessions like this. Coming to the topic, heart, as you know, is a mechanical organ, the primary function of which is to pump blood, and this is mostly gauged by echocardiography. The most important parameter in this regard, as you know, is ejection fraction, which is recommended to be measured by biplane Simpson's method, but usually done by eyeballing. Other methods are fractional shortening or velocity of circumferential shortening, VCF, key point substitution, do it in our earlier, and MAPC. But ejection fraction outstands it among these. And this is sought after parameter in any echo report. And this is most understood parameter. And this is the most utilized parameter. In fact, the most common parameter that we look for in, or anybody looks for in an echocardiography report. But is ejection fraction that reliable? Well, because of the limitations like this, that eyeballing is frequently employed for its estimation. One, that requires a lot of geometrical assumptions. Geometrical assumptions like we don't know whether our, in the initial days, we don't know whether our LV is a prolate ellipsoid or a hemi-ellipsoid, but now we use method of this. We calculate the volume of each and every disc. We sum them up and then come to a conclusion. All these lead ejection fraction to some minus points. Then a compromised EF, a reduced EF, usually signifies a point of no return. And there is great variability in the measurement, both inter and intra-observer. Then there is limited assessment of longitudinal deformation, which is the main contractility position of the ventricle. Usually, the ejection fraction estimates the radial deformation, and twist and torsion is not associated with ejection fraction estimation, and it is exquisitely load dependent. So because of these reasons, ejection fraction has got many limitations. To overcome these limitations, the pioneers in the field about 2 decades ago, they tell us that myocardium is being damaged before any change in EF by another parameter, which is deformation imaging. This entails measurement of myocardial mechanical performance by another virtue, which is strain. So what is strain? If you take the example of a muscle which has got a length of L naught, now if you subject this muscle to an external force, it will lengthen, increase in its length, and now the new length would be L1. In the same way, if this muscle contracts, then there is an intrinsic force, then also the muscle changes its length, but now it gets shorter. This change in length, if associated with in a ratio of the resting length and taken as a percentage, is strain. That is L1 minus L0 over L0 into 100. This is the strain. The change in length with respect to the resting length expressed as percentage is known as strain. Now, strain could be positive because here in this case, you see L1 is more than L0. This will result in a positive figure over here and you get a positive strain. But in most of the cases, as myocardium contracts, L1 is less than the resting length. So we have a negative strain because here L1 would be less than L0. Simple. Now, this created a bit of confusion. We know that minus 5 is bigger than minus 10 and minus 10 itself is bigger than minus 20. On the minus side, if you go on the digits, you will get more smaller number. But in a strain, we see that a more negative strain indicates better contraction and better strain. How? Let's see this. The same example that this muscle having a resting length L0, it contracted and the new length is 8 centimeters. So there is change in length of about 2 centimeters. Okay. In another example, the muscle contracted more vigorously and changed its size to 6 centimeters. As it changes size to 6 centimeters, the change in the size of the muscle is 4 centimeters over here. So applying the same formula, what would be the strain in the first case? It would be 20%, minus 20%, sorry. And in the second, it would be minus 40%. Now minus 40 is less number than minus 20, but this is indicating better contraction. So remember that a more negative value of a strain means better contraction. Some societies in the world, they objected to the use of minus sign and they said drop the minus sign so that people can understand it better. But no, the gurus of the field, they said no, we have to go with the minus sign. So a negative strain is always mentioned by a minus sign. How to measure a strain? There are different methodologies. Some are invasive, some are not. The first one is sonomicrometry. In this, crystals are applied directly over the myocardium. And as myocardium contracts and relaxes, the distance between the crystals changes and we can measure the strain. Now, naturally, this cannot be applied in our usual clinical practice. Second is MRI tagging. Although it can be done non-invisively, and it is gold standard, but availability, cost, time consumption, and acquisition complexity makes its use in daily routine not possible. The third, which has just been dropped out, is tissue Doppler. This tissue Doppler you use for assessment of diastolic function. You measure the mitral annulus velocity, S dash wave, E dash wave from septum, from lateral wall, and you also measure right ventricular function by measuring S dash velocity. This is by measuring the velocity of the myocardium with the use of tissue Doppler. Now, it has been done and it can be done, but there are very important reasons that it is tissue movement is assessed in relation to transversal position, and movement can be assessed in one directional only. Spatial resolution in tissue Doppler is limited, it is time consuming, signal to noise ratio is very high, and it is not highly reproducible. So that also went out of favor. Then comes speckle tracking. Yes, this is now the standard to measure strain non-invasively and conveniently because it has got good correlation with gold standard. It's highly reproducible and it is easy to perform in 2 and 3 dimensions. And the most important advantage of speckle tracking is that it is non-Doppler. We use 2D images. Doppler is not required and there is not much angle dependency. I will not say it is totally angle independent, but there is not much angle dependency even in 2D images. So these are the advantages. Going back to the basics. So what are speckles? You know, when we start doing echocardiography, we give ultrasound waves that go into the body. Some of them come back and produce an image on the screen. But much of that gets reflected because there are there are structures which are smaller than the wavelength of our ultrasound. These refracted or backscattered waves create spots which are known as speckles. Now, these spots, adjacent spots of the same shape, size, and other features, they are known as kernels. If you draw an M board over these spots, you can get lines like this. They are known as the just like fingerprints. Now, these kernels during systole and diastole, they move, and their movement can be traced very easily because they are within the image of 2 dimensions. As they move, they have got a velocity, they have got a direction of motion, and a particular distance that they cover. These 3 things are taken up by the machine in specific algorithms. This is the fast Fourier transform, which we also use for Doppler study. When we measure blood flow velocity, and there is another algorithm, sum of absolute differences algorithm. I will not go into the detail, but the machine utilizes these parameters, the graphs that they have created, and the machine gives us the strain value and strain rate as well. The basic of speckle tracking that enhances its image as compared to ejection fraction is because of cardiac mechanics. Ejection fraction is just one entity, as you will come to know. Our heart, mainly I'm talking about left ventricle. Left ventricle is composed of 3 layers of muscles, an inner, a middle, and an outer. The arrangement of fibers in these 3 layers differ in the sense that the inner fibers, they are more vertically oriented, creating an angle of 80 degrees with the horizontal. As the fibers sweep around the circumference of the left ventricle, they become more horizontally related. Now, these inner fibers, they are responsible for longitudinal contraction of the left ventricle. As fibers sweep around, they get less vertical, become more horizontal, so that the epicardial fibers form an angle of about 60 degrees with the horizontal. And these fibers, the mid and the outer fibers, they are responsible for contraction in the radial and circumferential direction. So now we have got 3 types of fibers which are responsible, because the combined contraction of which are responsible for our ejection fraction. But here you can see that longitudinal fibers, the speckles associated with these fibers, they move longitudinally, and hence they produce a strain known as longitudinal strain. This is the basic strain. This is the most valid strain. Now, along the radius of LV, as radius becomes less because of the movement of the speckles in the radial direction, that we call as the radial strain. And thirdly, along the circumference, as ventricle contracts, the circumference also goes down or decreases, and movement of speckles in this direction is traced and is known as circumferential strain. So here comes the advantage of strain over ejection fraction by this tri-layered arrangement of muscle fibers. The tri-layered arrangement of left ventricular myofibers complement each other during contraction. And EF, being the combined result of these layers, is not affected, especially during the initial stages of any pathological insult, as decreased performance of one layer, say inner layer, is offset by enhanced performance of other layers, radial and circumferential. So if the inner layer is diseased, radial and circumferential fibers, they come and make the ejection fraction normal. Although now in the tri-layered arrangement, what happened that there is disease process. So we have segregated the contractility of ventricle into three. This is the main advantage of strain. Now, subendocardial fibers being subject to ischemia the most are affected first, and longitudinal strain shows a decline first. Hence, measurement of longitudinal strain supersedes the ejection fraction assessment. I think this point is clear. This led Z2C et al. In a remarkable review that currently global longitudinal strain is considered the most accurate and sensitive parameter for the assessment of early left ventricular dysfunction. Is it robust? The measurement of longitudinal strain. Is this a robust parameter or not? The inter and intra-observer variability of GLS estimation ranges from 4.9 to 8.6%. This is much less than what we have for EF. And there's a study by Pharmaceuticals. In that, his group measured what errors are there in the measurement of common echo parameters like E over A ratio, IBS, LV, and diastolic dimension of posterior wall. And he found that among all these parameters, GLS has got the least mean error of measurement. So among all these parameters, GLS came out to be the most robust. There was a problem, I would say, yes, that the strain measured by different machines or different vendors, Siemens, Philips, GE, Epsilon, or Toshiba, the values came out differently. So that created a lot of hue and cry in the strain world, that this machine is giving me minus 20% strain, this machine is giving me minus 22, this machine is giving me minus 24. So how should we handle this situation? The strain ranged from minus 18 to minus 21.5. Yes, it was there because there was no consensus. But after a meeting by all these vendors and leading cardiologists, I think it was in Germany, that they decided that initially the recommendation was that same patient should be measured by the same machine longitudinally. That is, if you measure the strain today of one patient and want to measure it after 3 months, 4 months, then take the same machine. But this difference has now been very much sorted out, and the results are coming up, and it will be eradicated altogether, inshallah, very near future. How to acquire data for strain analysis by speckle tracking? For this, there are certain prerequisites. The most important is that you should have good quality images. In apical view, the 3 images, 4, 3, 2 apical view, and in short axis. In apical views, the length of the left ventricle should be nearly the same for all the 3 views. You should have a clear demarcation of the endocardium, the epicardium, and the LV apex should not be foreshortened in any of the view. For short axis views, the cut should be like that. It should be entirely circular, no oblique cutting. And the same features of endo and epi should be appreciated very easily for all the three views. For if you want to do strain of the RV, then you should always use an RV directed apical four chamber view, not in the routine four chamber. So image quality is a must. This is the basic requirement of strain imaging, that high quality images should be there. Second is frame rate, should be between 40 to 90 to avoid under or oversampling. Now you know very well how to increase frame rate. You reduce the ROI, the width and the depth of it, but making sure that epi and endocardial are clearly delineated. Third prerequisite is that the images, all the images should be ECG gated. All the images should be ECG gated because you want to know end systole clearly and end systole as well. Then heart rate. Initially, it was recommended to do it at a heart rate of 50 to 100, but now it can be, the machines are there, it can take up to 120, 130, 140, so that we can apply it for stress echo as well. And images better should be recorded in breath held, because with breathing there is translational movement of the heart, and then that can produce mistakes in measuring strain. These are the prerequisites. Once you have followed the prerequisites, then you go and get the apical 3 chamber, the 4 chamber, and 2 chamber. For some machine, it is mandated to use in this order. For other machines, it is not. You can take in any order. You have to time the events. For end systole, we take aortic valve closure, and this is best located in apical 3 chamber. This shows your end systole because this is the peak time of ventricular contraction and strain graphs, as you will see further on. Pulse wave Doppler can also be used, but better to use apical 3 chamber view. Once you have recorded the images, I will take just one view, is an apical 4 chamber view. You lay a region of interest over this. As you lay the region of interest, it should be in such a fashion that the central spots or the central markers should cover the mid of myocardium, the inner one, the endocardium, and outer one, the epicardium. It should all cover, the region of interest should cover the whole of myocardium. And for this view, it should not go into LA. And for apical 3 chamber view, sometimes it happens that the ROI goes into LV ocular tract and into aorta. That should not happen. Once you are satisfied with the image and the machine is also satisfied by clicking right signs, then you click for OK. The same steps are taken for 2 and 4 chamber, 2 and 3 chamber, and you get the parameters for strain analysis in a quad screen format, sometimes in a tri-screen format in some machine like this. This is usually for the GE machine and flaps, etc. In that, the results are displayed in 4 type of parameters. On the left upper are shown the segments with color-coded segments. On the right side, you will see graphs of each and every segment. I will explain just now. On the third, the lower left corner, you will see segments with strain values inscribed on each and every segment. And on the right lower side, you will see a curved M-mode image. Let me explain these all. There will be a color bar in every screen. Now this color bar differs from that color bar that you have in your color Doppler. In that, although red and blue color are used, but that is for towards and away flow of blood. Here, red and blue means lengthening or shortening of a segment, right? If the segment contracts and shortens, it will appear more and more in the hue of red. More the contraction, more will be the deeper would be the red color. And blue represents the lengthening of muscle. And more the lengthening, more hue, darker would be the blue color. These colors can change with the machine, right? So you have to know which colors are adopted, because in some Japanese machines they use yellow and green. So people will get different pictures on those machines. Now, this first result, it shows 2 walls. Every view has got 2 walls. In apical 4 chamber, we have got inferior septum on the left side and lateral wall on the right side. In apical 2 chamber view, you have got inferior wall on the left and anterior wall on the right. And whereas in three chamber view, you have got posterior wall on the left and anterior septal wall on the right. So you always have two walls, and each wall is divided into three segments: base, mid, and apex, just like we do in for wall motion. Now, every wall in every segment has got the every segment in every view has got the same color. Like this, the left-sided wall here, it is inferior septum. The basal segment would be represented by yellow color, the mid by light blue, and the upper one near the apex, apical segment, would always be represented by green color. And this color scheme on the right of purple, dark blue, and dark red would be the same. Now, if you change the view, the balls will remain the same. On the left side, the same colors. On the right side, the same color. You take three chamber view, again, same scheme will be there. Only these six colors would be used. Now, these are the graphs. Each segment is represented by a color, and the color of the graph corresponds to that segment. Yellow color means basal inferior septum in this view. So the graph for that contraction is over here. Purple means apical lateral wall. So the graph of apical lateral wall is over here. So colors of graph correspond to the colors of the segments. We have to study graphs very thoroughly because in each view you have got six graphs of six segments. Like this. As QRS, after QRS contraction starts, the graphs go down because as the segment contracts normally, it reduces its size. So the strain becomes more negative. So it gets a more negative value till it reaches the point at which there is aortic valve closure, which is end systole. This is the peaking of nearly all the segments. And then diastole starts, and as diastole starts, the segments lengthen again because of relaxation, and they assume the same length at the end of diastole. So this is the peak systolic time, this is the end diastolic time, and this is the early systolic time. The six graphs show their pattern. You can see that the yellow color representing basal inferior septum has got less strain as compared to purple color, which is the apical lateral wall. So on viewing the graphs, you can see that some segments have got better contraction than others. An average of these six segments would be given by the machine in a dotted line and also on the report. The third parameter which you will get is the strain inscribed color-coded segment. That does not need any much explanation. But this curved M mode, again, the colors, they are important here. Now, this colored M mode is like that. It's a ribbon-like. In that, the whole process of systole and diastole is represented in a single line, like this. The first ribbon corresponds to the basal inferior septum. The second ribbon corresponds to the mid, and third ribbon corresponds to the apical inferior septum. Now, because it's a curved M mode, so we can get the M mode of the other walls also on the same page, like this. That the apical septum is represented by purple color. So all the segments are represented by ribbons, and what is happening to them during the entire process of systole and in diastole. You can see that as contraction is proceeding, the color has been changing from light pink to darker pink to red, light red, and darker red, because as they are contracting, the strain becomes more and more negative. Now, at the end of systole, when they start to relax, the color again changes. It was red initially, it becomes more lengthened, light red, then light pink, and ultimately at the end of diastole, it becomes blue because it has lengthened to the maximum. So in this view, just on one image, you can diagnose which segments are contracting well and which are not. Ultimately, you get a polar map, a bullseye map. This is just like wall motion scoring index, in which the basal part is represented by the outer circle is represented by the basal segments, the mid circle by the mid segments, and apical segments by the inner circle. With the segmental value of each segment inscribed. The arrangement of anterior, lateral, inferior, and septal wall is just like wall motion scoring index. And in the tabular form also, the machine gives you the average strain for whole of left ventricle and for individual views as well. Normal range for GLS has been estimated to be minus 15.9 to minus 22.1. This for GLS. Then for circumferential strain, you have to take two views at the base and at the mid segment. Apex is not required, and you lay the ROI over it, covering all the myocardium in both the views. And now, in circumferential strain, the circumference of LV reduces as it contracts. So you have got again negative strains for circumferential strain as well. Negative graphs. The machine will give you average, the individual segmental strain circumferentially as well as the global strain for that view. Normal range is minus 20.9 to minus 27.8. Similarly, we do radial strain, but in radial strain, the difference is that in radial contraction, the muscle thickens. That is, it becomes, the L1 becomes more than L0. So, radial strain is represented by positive graphs and is a positive strain. And the range is 35.1 to 59%. See, the negative sign has gone. Radial and circumferential strains have been mentioned in literature to be assessed for, they are used for the assessment of disc synchrony and lead placement in CRD. But there are issues of reproducibility, so that's why it has not gained that much of efficiency as compared to the longitudinal strain. Another parameter which you can gauge is twist and torsion. If you stand on the foot side of the patient's bed and see his ventricle contracting, it contracts like that. The base of the ventricle contracts in a rotates in a counterclockwise, whereas the apex moves in a the base moves in the clockwise and the apex moves in a counterclockwise direction. You can lay an ROI of the base and the apex, and you can measure twist by subtracting apical rotation from the basal rotation from apical rotation. I will give you the example, which will explain it very well. It has been said that basal rotation should be shown in a negative way, in a negative graph, and apical rotation should be shown in a positive graph. Here blue represents apical and this is basal. You subtract them, you will get the average rotation, average twist. If you divide this twist with the length of the ventricle, you can get torsion. These are used for diastolic strain rate, estimation, untwist velocity, and time to peak untwist velocity have been used as measures of LV diastolic function with variable results, not much applied. You get an apical view, and you see, because of counterclockwise rotation, you get positive strain, positive rotation, and a basal view, and you get a negative strain. Here, the apical rotation is 4 degree and basal rotation is minus 6. If you apply the equation, it will come to 10 degrees, the twist. I will skip over this. Yeah, this is a very important parameter which you can gauge from strain analysis. I've told you that as the segments contract, they produce negative strain and reach a peak value, which is mostly happens at the time of aortic valve closure. Now, this peaking of individual segments can vary. Some peaking early, some peaking late, some peaking at aortic valve closure time. This variation is known as mechanical dispersion. And if you measure the standard deviation of this mechanical dispersion, that has got importance in patients with ventricular arrhythmias post-MI. There was a study by Waga of 594 MI patients who were followed up for 30 months, and he noted that in patients who showed arrhythmia post-MI, the mechanical dispersion was 63 milliseconds as compared to those who didn't. That was 42. This was statistically significant, giving a hazard ratio of 1.7 for measuring mechanical dispersion. This was also mentioned by him again and his group in another study in which he used the cutoff point of 70 milliseconds in patients of post-MI who had an ICD implanted. Now, those patients who showed mechanical dispersion of greater than 70 milliseconds, they have got more events. Cumulative arrhythmia survival-free survival was less in those who have got mechanical dispersion of greater than 70 milliseconds as compared to those whose mechanical dispersion was less than 70 milliseconds. So they gave a sensitivity and specificity of 70 millisecond values up to 65% and 92%. So mechanical dispersion can be assessed easily on strain analysis. Another parameter which we can see is early systolic lengthening. These two parameters, the early systolic and the next one that I'm going to tell you, postsystolic shortening, they help us in identification of ischemia. Now you have seen that normally the graph as systole starts, they go on towards their downward journey. But what happens in ischemia? The ischemic segment is slow to contract. The normal segment starts contracting, but the ischemic segment is slow to contract. It takes time. Now, as the ischemic segment is not contracting, whereas the normal segment is contracting, there is a rise in pressure in the LV. This rise in pressure of LV causes the ischemic segments to lengthen, and this can be assessed by a strain in this form. See, instead of going downwards, the ischemic segments, they are going upwards, and the length of this early systolic lengthening, this is known as early systolic lengthening. The length of this early systolic lengthening has been found to correlate with the ischemia, the number of segments and the extent of ischemia. Similarly, another feature of strain is postsystolic shortening. It has been noted in ischemic segments that they are slow to start contraction and they are slow to stop contraction. So at aortic valve closure, all segments should have stopped their contraction. But ischemic segments, they continue their onward journey of contraction in early diastole. And this is known as post-systolic shortening. And this has also been found to be a useful parameter for assessing ischemia, whether it is there or not.
Dr. Imran, can you please wrap it up in past 30 minutes?
Sorry, time, yes, sir. Okay. 10 minutes, just give me 10 minutes more. Now, the utility of strain is for diagnostic and prognostic importance.
Jan, would you please wrap it up in a couple of minutes? We have another speaker as well.
Okay, sir. Okay, I will just show a few slides, 4 or 5. Not more. This is the utility of strain. You can see in hypertension, the 4-chamber view and the 2-chamber view. You can see the contraction is very good. The usual method is what we call 2D. Simpson's method measured the strain as 70, measured the EF as 70.5. But when strain was done, it was found to be minus 14%. That is, this shows that this good contracting ventricle has got subclinical LV dysfunction. Just one more slide. This shows the utility of strain measurement as compared to EF in patients who undergo chemotherapy. The support trial, they got 331 patients, 166 monitored by EF. They will give cardioprotection treatment whenever there is a drop either in EF or in GLS. If the drop in EF is more than 10%, they will give it cardioprotection, or if the other group was monitored by GLS, if there is a drop in GLS of 12%. So cancer patient, they were given chemotherapy and they were monitored by abnormal ejection fraction response or abnormal GLS response. What happened? That they give cardioprotection if there is an abnormal GLS or an abnormal ejection fraction. What happened that those who are monitored by EF, they had got more LV dysfunction at the termination of treatment, 65%. Whereas those who are monitored by GLS, they had got less, just 39%. Similarly, normal LVEF at the end of the chemotherapy was noted more who were monitored by GLS as compared to those who were monitored by ejection fraction. This shows the supremacy of GLS estimation for your cardioprotection treatment. I will skip all this. This is very important. The indications for CRD are that the patient should have function class 2 or 3 and EF less than 35% and LVB better. The QRS duration 120, 150 or more than 150. But all these patients, when they are subjected to CRT therapy, did not respond. Even 1/3 of them did not respond. It is because the LVBs have got different. In the first case, this is known as typical LVB. in which the segments are showing dyssynchrony. Some are relaxing, some are contracting, whereas some patients with LVB do not have that much of dyssynchrony. The segments contract almost synchronously. Now, applying CRD in this segment of patient would be useless. This has been shown in a trial of 208 patients that those who show typical LVB and implanted with CRD have got less events as compared to those who are implanted in this type of group in which there was not much dyssynchrony. So the assessment of synchrony can be very easily done by strain analysis. There's uses of strain in various states like prognostic assessment for valvular heart disease, prognostic assessment for chemotherapy, I've told, prognostic assessment for ischemic heart disease, etc., etc. I've skipped all that and just come on to the other type of strain that we can measure is the left atrial strain. Now, left atrium is not a passive chamber. It shows three phases. During systole, it expands and is known as a reservoir. Then, as the end of systole, when the mitral valve opens, the blood gushes. This is known as the conduit phase. And in the last third of the diastole, atrium contracts, giving it a contractile phase. Now, all these phases can be measured by strain by applying the ROI over the 4-chamber view and over the 2-chamber view and measuring the strain values as the atrium expands during the reservoir function and as it contracts during the conduit and the pump and the contractile phase. As it expands in the reservoir phase, when the mitral valve is closed, the strain is positive, and as it contracts during the conduit phase, the strain becomes less and more so less in the pump phase. These have got very important, and Dr. Shabaz, I want your attention in this regard that we measure diastolic function by very complicated type of parameters, 4 or 5 parameters, and then we conclude them and then come to a conclusion. This Singh et al. Has mentioned this, and it has also come in textbooks of echocardiography that just measure the reservoir strain. If it is more than 35%, its diastolic function is normal, and if it ranges from 35 to 24, it is diastolic grade 1 dysfunction. If it is less than 24, it is grade 2, and if it is more or less, it becomes less than 19, then it is grade 3 diastolic dysfunction. So as diastolic dysfunction proceeds, the peak reservoir strain goes down and down. So just by measuring one parameter, you can assess the grade. And the third point that you measure during diastolic function is LV fling pressure. For that, again, you have got a complicated algorithm. You measure the 3 values. First, you see EA ratio, then divide it into 2, into 3, whether it's less than 0.8 or more than 2 to signify a normal fling pressure or elevated fling pressure. And for intermediate values, you again measure the 3 things. This is the current guideline. Now, if 2 of them are congruent, you can say it's either normal or abnormal. But if only 2 parameters are available and you cannot say because they are discongruent, one is positive, one is negative, then what to do? Whether LV fling pressure is increased or not, strain comes to your help as a supplementary parameter. It has been found by Noeke in the remarkable study that reservoir strain less than 18% or pump strain, that is contractile strain, less than 8% signifies elevated LV fling pressure. On the other hand, in patients with normal LV systolic function, LA pump strain greater than 14% supports LV fling pressure. I think these recommendations will soon come in the guidelines for the assessment of diastolic dysfunction. We'll skip on to this. Then assessment of right ventricle can also be done.
Dr. Imran, would you please, because we have to have some interaction as well, but I think because of the long talk, I think we can allow only one question from each center. One question from Lahore and one question from Karachi. From Lahore, anybody wants to ask a question?
Hello, Dr. Imran. How much have you applied your LA strain in evaluation of
very regularly now, and I'm surprised that why it was not being applied regularly. Even on a day-to-day basis, I'm applying it. I am getting the same result that has been mentioned in this study, that a reduced LA reservoir strain.
My next question is, have you applied this in cases of patients who have got scandum ASD and Have you done it before and after the occlusion of ASD, or you are done without ASD's patients?
No, not yet in ASD's patients, mostly in patients of actually ischemic or cardiomyopathic type of patient that we usually, or hypertensive patient that we usually get in our routine practice, not really for ASD, but this RV, I am going to emphasize that this I have been applying for, because I get a lot of patients with COPDs and all that, RV function, which we usually measure by TAPC, FAC and RVS dash velocity, but that all come nearly normal. But when I apply RV strain, that gives me reduced figure. So just like GLS of LV, we have got a subclinical dysfunction of RV as well in these cases. In fact, I will mention this study, yes, that Morris et al., they said that although the normal parameters that we measure for like TAPC, S-dash and FAC, they were normal in patients with HF-ref, but RV strain was not. So RV strain supersedes these parameters also. I have not applied for ASD cases, but inshallah, I will do that very soon if you are saying that like that. Right, sir?
Thank you, Dr. Imran. Thank you, Dr. Imran. It was really a nice talk and very comprehensive. कोई क्वेश्चन यहाँ से अगर इस सेंटर से है तो मे बी वी कैन टेक वन क्वेश्चन फ्रॉम हियर. सो अगर कोई और क्वेश्चन नहीं है तो अगेन थैंक्स टू डॉक्टर इमरान फॉर अ वंडरफुल टॉक.